for cystic fibrosis. Now for cystic fibrosis, just think serous mucus for cystic fibrosis. We find sticky mucus in the lungs and digestive system, which can clog the respiratory tract, leading to major oxygenation issues, and also obstruct the pancreas, leading to digestive issues, since insulin and enzymes can't get out to help digest fat and protein. This leads to poor weight gain and failure to thrive, meaning that eventually these will lead to a shorter lifespan if not properly cared for. Now for the pathophysiology. Cystic fibrosis is a genetic disorder where a defective protein that normally transports sodium and chloride in sweat and saliva glands within the exocrine glands now causes mucus secretions to be thicker and stickier than normal. This mucus builds up in the lungs, leading to recurrent respiratory infections and damage the alveoli, resulting in pneumothorax or collapsed lung. Very, very deadly. So the signs and symptoms to watch out for, and write these down, these are the most tested. Respiratory failure is priority, specifically oxygen saturation and airway. So look for the key terms: low pulse oximeter reading, normally between 95 and higher, and sudden drop in oxygen saturation. Now, these are critical. Write down these key terms. These are deadly signs and are typically the most tested signs, as it can indicate early sign of critical airway clogging or even pneumothorax. So these findings would need immediate action. Now for the other signs that are common and to be expected: recurrent lung infections, as well as blood-tinged sputum. Now this might sound weird as a normal finding, but just think about it here. The thick mucus not only creates a perfect environment for infection to flourish, but it also causes damage to the blood vessels in the airway from excessive coughing, and this results in blood-tinged sputum. Now, weight loss and loss of appetite is also to be expected, due to the clogging of the pancreas that normally secretes digestive enzymes to help break down those carbs, fats, and protein. So impaired digestive enzymes results in poor breakdown and poor absorption of essential nutrients. And lastly, constipation and loose fatty stools, called staturia, are common due to the mucus buildup and lack of enzymes to help break down fat, as well as lack of water and salt that normally keep the intestines lubed up. Now for diagnostics, we have a sweat chloride test as well as DNA and stool tests. But I wouldn't focus on these too much as they were not commonly tested on exams or even boards. Now, nursing care, this is the most tested here. Now, don't try to memorize this. Always think of the patho here. For cystic fibrosis, we have serous mucus that clogs the lungs and leads to poor digestion in the digestive tract. So number one is diet. We always encourage high calories due to the impaired digestion and impaired nutrient absorption. And always we give enzymes with meals to help with digestion. So the key term here is with meals, not before and not after, but with. Now, number two is the mucus. So we increase fluid intake to help thin that mucus. We also encourage exercise to help loosen that thick mucus in the lungs and promote lung expansion. We use chest physiotherapy, which again helps loosen mucus, and postural drainage, which also helps to loosen that mucus. Now, Kaplan mentions expected intervention for clients with cystic fibrosis. The key term there was postural drainage as an intervention. Now, lastly, a really weird one here is number three, financial counseling. Now, this was mentioned on a few different exam question banks, since the financial burden of this long-term disease should be discussed and planned for. And lastly is pharmacology. Now, the most tested drug to focus on was acetylcysteine, brand name Mucomyst. So let's play that segment now from our pharmacology master course. Next is acetylcysteine, brand name Mucomyst. The indication here is it helps loosen and thin mucus secretions for serious mucus like cystic fibrosis. So guys, think serious mucus like cystic fibrosis We use acetylcysteine. Now, it's the antidote for Tylenol overdose. So we think acetylcysteine blocks acetaminophen. And it's also given before the cath lab to protect the kidneys from that contrast dye. So we always say acetylcysteine protects the kidneys. Big side effect that we have to be cautious with asthmatic patients. Now, the big key point here is it's not safe and can cause worsening bronchospasms. So always clarify any prescription that is given for asthmatic patients. And a big patient education, guys, the rotten egg smell, that's completely normal. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to Bronchoscopy is a procedure that allows visualization of the larynx, trachea, bronchi, and deep lung using a flexible scope. Now, it's done for 3 common reasons. Either to take a biopsy of tissue, like when checking for cancer, or to give a lavage to wash out the lungs, or number 3, to suction out deep sputum or even a foreign object. Now, the tube is inserted through the nose or the mouth or even the endotracheal area, passing the throat. So naturally, a gag reflex and even a laryngeospasm are a big concern. So before the procedure, the patient is given mild sedation, which naturally makes the vital signs low and slow. And a topical analgesic like lidocaine is applied to the throat to prevent that gag reflex. Now, post-procedure care, it's priority to monitor for these key signs. So write these down. Laryngeospasm, also called a stridor, which is that sudden spasm of vocal cords which can close the airway entirely. We call this sound a stridor squeak, since it sounds like a squeaky door. And number 2 is the bright red, blood-tinged sputum called hemoptysis. Now, the key word here is bright red blood. If you see those key words on the NCLEX or your nursing exams, it typically means an active bleed. Very serious, especially after a biopsy or any surgical intervention. Both conditions are priority here and require immediate notification of the HCP provider. So remember, stridor squeak or that laryngeospasm and bright red blood. Now, Kaplan mentions post-bronchoscopy, the priority findings to report to the provider immediately. Select all that apply. So blood-tinged sputum that is bright red, as well as a stridor and increased dyspnea. So the key terms there are bright red, that blood-tinged sputum, and stridor. So remember those key terms. Now, don't let the NCLEX trick you here. Low vital signs are completely normal. Just think about it. Low respiratory rate and low oxygen saturation, like in the low 90 percentile. It's normal and to be expected. Many students get this wrong. So again, just think about this here. The patient just had mild sedation, making everything low and slow. As well as the absence of a gag reflex is completely normal and to be expected too, since that numbing agent or that topical analgesic has been applied to the throat region to prevent that gag reflex. Okay, now switching gears to nursing care, it's critical to write this down. Clients must remain NPO until alert with a positive gag reflex, since these clients are at high risk for aspiration. Typically, a swallow eval is priority before eating can resume. And lastly, a big NCLEX tip. Words like newly transferred or returning to the floor typically require a priority assessment, since these clients have the greatest risk of becoming unstable. So in this case, the priority assessment, or which client to assess first, would be the patient returning from a bronchoscopy or newly transferred after the procedure. So just remember, always assess these patients first. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the Now for filleal chest and rib fractures. The patho and signs and symptoms are pretty simple here. We have broken ribs, which typically result after any major trauma, like a car accident, falls, in even fights or the like. And filleal chest is a type of rib fracture that is a life-threatening medical emergency. It occurs when a segment of the rib cage completely breaks and becomes detached from the rest of the chest wall, looking sort of like a punched-out segment of ribs, resulting in funky chest wall movement when breathing. Now, this key sign is called paradoxical chest wall movement. Now, write that one down. This key term is commonly tested. The ribs sort of suck inward during inspiration and flow outward during expiration. So just think F in filleal chest is F for funky chest wall movement. Now, we also get extreme chest pain and shallow respirations. Now, the extreme pain during breathing leads to limited chest wall expansion, resulting in very shallow respirations and decreased lung expansion, which is very deadly since it can lead to alveoli collapse called atelectasis, which traps infection leading to pneumonia and also leading to decreased gas exchange. Now, if this gets bad enough, it can have deadly complications. That high risk for infection, as mentioned before, the pneumonia is very common, as well as high CO2, that carbon dioxide retention, which puts the body into an acidotic state, since there's less air movement, meaning less gas exchange, which, if severe enough, can lead to acute respiratory failure from extreme acidosis. This is called hypercapnic respiratory failure. So just think high CO2 results in hypercapnic respiratory failure. Too much CO2 can cause that respiratory failure. So in order to prevent this, we must implement these interventions. Number one, the priority is pain control. So yes, administer prescribed opioids like morphine, hydromorphone, and hydrocodone. So just look for the O's to know it's an opioid. So on exams and even the NCLEX, anytime you get a question and see the words rib fracture or filleal chest, or even the key term paradoxical chest wall movement during respirations, well, always the number one first priority is pain control. Now, don't let the NCLEX trick you here. Yes, clients will already have those shallow respirations and report pain upon inspiration. This is normal with rib fractures. So there's no need to notify the provider or the doctor here, since this is to be expected. And yes, opioids make the vital signs low and slow, slowing the respiratory rate even further. But the NCLEX here focuses on lung expansion, which is only possible with proper pain control. Many students get this wrong and don't want to give the pain meds. So just be sure to give those pain meds. Now, number two is pulmonary hygiene. This can only be done after pain meds are given and pain is controlled. We TCDB, turn, cough, and deep breathe, and also use the IS, that incentive spirometer, to re-expand the lungs and prevent that atelectasis, those collapsed alveoli, which prevents the deadly pneumonia and increases gas exchange to prevent that deadly CO2 buildup. All right, guys, that wraps it up for this segment. Don't forget to take your quiz and download the study guides. Hemothorax versus pneumothorax, which I call pneumothorax, but the P is silent there. Now, it's very simple here. Just let the name help you. So for hemothorax, just think hemo meaning blood, like hemoglobin. Blood collects in the pleural space, which is that space between the lung itself and the chest wall here, resulting in the lung collapsing in on itself from all the pressure buildup from the blood. Now, the key sign is dull resonance upon percussion, like tapping a paint can or a jug of water. So the memory trick here is the double L's. Just think L for dull resonance as L for blood or even fluid, sounding sort of like tapping a paint can or remember that jug of water from all that fluid buildup, especially blood. Now for pneumothorax, pneumo think lung, like pneumonia. The lung collapses due to air in the pleural space. Now, the key sign here is hyperresonance, like tapping a hollow drum or a hollow tree. So the memory trick is the double H's. H for hyperresonance, just think H for high air. Now lastly, tension pneumothorax. This can result from an open pneumothorax, where air gets sucked into the pleural space when breathing in, and the air gets trapped and it can't get out. This is known as a sucking chest wound. Now, this typically happens from a penetrating chest trauma, like a gunshot wound, a knife stabbing, or something else that leaves a hole in the client's chest. Now, this is commonly seen in the hospital setting when we prematurely disconnect a chest tube. Now, a side note here and a general NCLEX tip. Do not remove anything that penetrates the body. We always leave it in place. We never pull out a penetrating foreign object, since the client could bleed to death. Now, whatever the cause, the air pressure within this lung space can get so great that it collapses the lung, as well as, key terms here, it pushes the trachea and the organs to the side. This is known as tracheal deviation. So just think of the double T's. T for tracheal deviation, T for tension pneumothorax. Now for the common general signs and symptoms for all these conditions, we typically see dyspnea, that shortness of breath, tachycardia, that fast heart rate, tachypnea, that fast respiratory rate, as well as diminished breath sounds on the affected side, which makes sense because that side of the lung is either filled up with blood or with air. Now, Hesse had a question about this. During central line placement, the patient develops dyspnea and tachypnea, and the provider asks for a chest tube tray. The answer is suspected pneumothorax, that popped lung. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love, share with a classmate, and even your instructor. See you guys in the next videos. Now for influenza. This is often called the flu for short, in influenza. Now this is an infectious disease caused by the influenza virus. So it's not a bacteria. Therefore, antibiotics will not work. So please be sure to write that down. Not a bacteria, so no antibiotics. Now I know we're going to cover that later in the pharmacology area, and we're only doing patho right now. But just know that viruses are totally different than bacteria. Now for types of influenza, we have A, B, and C, and it's constantly mutating. That's why every single year a new flu shot is needed to protect against new viruses. So again, annual vaccinations are recommended. Now in terms of manifestations or signs and symptoms, it's common flu-like symptoms. So fever, fatigue, and body aches. All the symptoms can range from mild to moderate to very severe. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love, share with a classmate, and even your instructor. See you guys in the next videos. Now let's review lung cancer, also known as lung carcinoma. This is a malignant lung tumor, meaning it's a deadly cancerous tumor characterized by uncontrollable cell growth of tissues inside the lung. Now this growth can spread beyond the lung by the process of metastasis, basically spreading into nearby tissues or other parts of the body, which we'll cover in a moment. Now for the causes. The number one cause is smoking. 90% of cases of lung cancer come from smoking. Number two is a secondhand smoke. And number three is exposure to asbestos or other carcinogens. For example, number four, air pollution, or number five, family history of lung cancer in terms of genetics. Now for early manifestations or signs and symptoms, persistent productive cough. This one is huge. Be sure to write that down. As well as hemoptysis, or basically coughing blood. And hoarseness in the voice, and dysphagia, difficulty swallowing, or swallowing difficulties. Now, it's not to be confused with dysplasia, the abnormal development of cells within tissues or organs. So just look for the G in dysphagia as G for swallowing in the GI tract for dysphagia. Okay, now for complications. Paraneoplastic syndromes is a big complication here. These are a set of uncommon disorders with very interesting manifestations that develop with someone who has cancer. Now, it's due to a production of chemical signals and molecules such as hormones and cytokines by tumor cells or by an immune response against the tumor, often leading to endocrine dysfunction. Now, in terms of metastasis or metastasis, this is the spread of cancer to other parts of the body, most notably to the bones. So if you have a lung cancer patient complaining of bone pain, it's most likely metastasis. Now for diagnostics, imaging can be done with a CT scan, an MRI, or chest x-ray, and even a biopsy can be taken, which is simply a sample of tissue that they put under a microscope to see if the cancerous cells are malignant or benign. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download. Now for obstructive sleep apnea, also called OSA. So just think OSA as obstructive snoring airway. It's what happens when the tongue or muscles in the pharynx block the airway partially or completely. This blocked airway results in moments of no breathing and no airflow, called apnea, typically for about 10 seconds or more, hence the name obstructive sleep apnea. Now, these momentary episodes of apnea result in less oxygen in, so we get hypoxemia, and less CO2, that carbon dioxide, out, and ultimately forces the body to wake up in order to get a breath of oxygen. And this makes quality of sleep and a good night rest nearly impossible. Now for the key signs and symptoms to write down. In the daytime, we get morning headaches, daytime sleepiness, and chronic fatigue from the lack of quality sleep at night, as well as irritability, mood swings, and even depression. Just think about yourself when you don't get enough sleep. Now, at night, the key terms here are snoring and episodes of apnea. Now, write these two down. Remember our memory trick here. Think OSA. You have an obstructive snoring airway. Now, there was a HESI scenario asking about the findings that support obstructive sleep apnea. Select all that apply. So the key terms here, chronic fatigue, as well as reports of going to bed early, sleeps for 8 hours, and key terms here, still does not feel rested upon awakening. And lastly, an obese man with hay fever that causes predominantly nasal symptoms. So the key term there was obese man. Now, speaking of obesity, the causes here. Simply think OSA, like obstructive sleep apnea. O for obesity and being overweight. That was the number one cause and biggest risk factor for OSA. Next is S for sedatives before bed, like benzos or opioids, and even A, alcohol, which is also a sedative. This can lead to too much relaxation of the muscles in the throat area, leading to more obstruction and leading to more sleep apnea. So for patient education, the number one thing we teach here is losing weight as well as exercising. Number 2, limiting alcohol intake. And then lastly, the no-nos here. No napping during the day. This can make it more difficult to sleep at night. No sedatives at bedtime. Again, too much relaxation of the smooth muscles at night can cause more sleep apnea. And lastly, an interesting one. No eating bedtime snacks or eating dinner too late. This can cause an increase in weight gain and also obstruct the airway at night. Now, in terms of interventions, the number one thing to write down here is the CPAP, continuous positive airway pressure. This device uses a mask to pump air and a positive pressure into the nose and mouth, which keeps the pharynx and tongue from collapsing backwards. I'm sure you guys know someone who uses this at night, and if not, you'll probably notice someone in your family who uses one now. Now, a highly tested key point for a client on a CPAP. The first action for a client on a CPAP with low O2 saturations. Number one thing you do is check tightness of the straps and the mask. Now, this is especially done if the patient's O2 sat goes down at night. These masks are known to be jarred loose at night from movement during sleep. So just be sure to check the tightness of the straps and the mask to ensure a snug fit over the face to prevent air leaks. So once again, if the O2 saturation goes down at night, be sure to assess the CPAP straps as well as the mask as the first action. We're not assessing the lung sounds or even the mental status here. Many students get this wrong. So if the question states low oxygen SATI on a CPAPy, then you got to check those strappies. Okay, now Hesse mentions a patient non-compliant with a CPAP. You want to use a BiPAP instead of a CPAP. So a little side note here. CPAPs give continuous pressure during inhalation and exhalation, which is more uncomfortable. Now the key difference is a BiPAP uses pressure accommodation for normal breathing, but that wasn't really tested as a direct question. So really the key thing to know is we use a BiPAP instead of a CPAP as a secondary resource. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love, share with a classmate and even your instructor. See you guys in the next video. Pleural effusion versus thoracentesis. Starting with pleural effusion, think plenty of fluid in the lung space. More specifically, fluid collection in the pleural space, greater than 15 mLs of fluid. This fluid prevents full expansion of the lungs and results in decreased gas exchange and atelectasis, basically the collapse of the alveoli. So less oxygen in and less CO2 out. So naturally, we see a buildup of CO2, that carbon dioxide, in the body, resulting in more acid, pushing the body into acidosis, as well as fluid-filled alveoli, leading to that atelectasis. Again, remember, that's the collapse of the tiny little air sacs. Now for the causes of pleural effusion, typically caused by pneumonia, that lung infection that fills up the lungs with fluid, and even heart failure, where we see heavy fluid buildup in the body and the lungs. So just think HF for heart failure, HF for heavy fluid inside the body. Now for signs and symptoms, the key signs to write down is number 1, chest pain during inhalation, taking a deep breath. Number 2 is dyspnea, that shortness of breath, obviously since the lungs are filled with fluid. Number 3 is diminished breath sounds on the bottom or lower lobes, aka the lung bases. And number 4, a big one here, is dull resonance on percussion, kind of like slapping a paint can or a jug of water. So just think of the double L's here. L for dull resonance, L for fluid-filled lungs. Now don't let the NCLEX trick you here. It's not hyperresonance. That's high air trapping inside the lungs. So write down these 4 because these are the key signs that came up multiple times on a few Select All That Apply questions. Now Kaplan states, suspected pleural effusion findings, decreased breath sounds noted in the lower lobe. So for interventions, the number 1 priority is to drain that fluid. So the key term here is thoracentesis. We literally stab the patient in the back with a big old large bore needle. Okay, it's not really that violent here. We gently place the needle through the intercostal space, or basically that space between the ribs, and we gently puncture the lung in order to drain the fluid. Now, before we start the procedure, number 1, we must prevent the patient from bleeding out. So always highly tested, so write this down. You must stop all blood thinners. So antiplatelets like aspirin and clopidogrel, brand name Plavix, and anticoagulants like warfarin and heparin, and even enoxaparin, or lower molecular weight heparin. The second thing we do is have the patient sign a consent form, typically done with all surgery or invasive procedures where the HCP will be stabbing the patient with a sharp object. Lastly, we get a chest x-ray before and after the procedure to compare fluid and lung expansion. Now, after the thoracentesis, here's the key concept. ATI mentions correct instructions after the thoracentesis. Have the client take deep breaths after the procedure. Now, this helps re-expand the lungs and promotes adequate oxygen exchange. And we also keep the head of the bed up in semi-Fowler's position and have the client lie on the unaffected lung to keep the bad lung up. This promotes lung expansion as well. Now, thoracentesis has good news and bad news here. The good news is we remove the fluid from the pleural space and improve lung expansion. And we can send the fluid to the lab to help diagnose the root cause of the pleural effusion. So whether it's from an infection or even checking cancer markers. Now, the bad news here is the big complications. So just think about it here. We are sticking the patient with a large bore needle directly into the lung space. This can cause a deadly pneumothorax, basically a popped lung, or even a hemothorax, that blood in the lung, and even introduce infection. So post-procedure, the key assessment findings that require immediate intervention, and we must report these to the HCP immediately. Key term again is pneumothorax, that air inside the lung space. So we see asymmetrical chest expansion, or basically unequal movement of the chest, and, key term here, decreased breath sounds on the affected side. We also see hyperresonance, indicating high air inside the lungs. So just remember H for hyperresonance, H for high air in the lung space. And lastly, deviated trachea from a tension pneumothorax. All that air pressure inside the lung space builds up and pushes the trachea to the opposite side. That's why we always take a chest x-ray before and after the procedure to document any abnormalities. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love, share with a classmate, and even your instructor. See you guys in the next videos. Pneumonia is a nasty infection causing severe inflammation in the lungs and causing the alveoli to fill with mucus, fluid, and debris. Now, this extra fluid can make it harder to breathe. So the memory trick, just think P for pneumonia as P for a plague of inflammation inside the lungs that fills the alveoli with fluid. As you know, the alveoli is the place where gas exchange occurs. So normally we breathe oxygen in and carbon dioxide out. But with pneumonia, all this fluid, mucus, and debris fills the lungs and leads to impaired gas exchange, where CO2 can't get out and oxygen can't get in. This results in hypoxia from that low oxygen and acidosis from too much carbon dioxide. So just think carbon diacid, since too much CO2 can put the body into acidosis, and also impaired ventilation, as the body tries desperately to get air through those fluid, mucus-filled alveoli. So write it down. Impaired gas exchange is typically the most tested nursing diagnosis for clients with pneumonia, which leads to ineffective breathing pattern as the body fights for air. Now for the signs and symptoms, before you start memorizing, just think of the patho here. Again, P for pneumonia, just think P for a plague of infection inside the lungs. Now write down these top 6 most tested key terms here. Number 1 is altered mental status. We see restlessness, agitation, and confusion. These 3 are the earliest signs of hypoxia. So write them down because they are critical, since it can lead to deadly respiratory failure. Now, the brain is very sensitive to oxygen, so these key words also cross over for other conditions where we have low oxygen in the brain, like increased ICP and even strokes. Now, number 2 is fever. Key term here, over 100.4 or 38 degrees Celsius. Always an NCLEX favorite, and that loves to show up on exams. Number 3 is a productive cough with yellow sputum from that infection. So again, pneumonia, just think that plague inside the lungs, which leads to number 4, fine or coarse crackles upon auscultation from fluid and mucus-filled lungs. And then number 5, dyspnea, that shortness of breath. Okay, now the biggest sign that pneumonia is getting worse is key term pleuritic chest pain with pleural friction rub. That must be reported to the HCP. It's described as a sharp chest pain upon inspiration or breathing in or upon coughing. Now, sometimes it's described as stabbing or burning pain inside the chest that increases upon inspiration or with the cough. Pleurisy is a major complication of pneumonia, as inflamed lung tissues rub together, sounding kind of like rocks rubbing together. So we call it pebble friction rub for pleural friction rub, or even sounding like sandpaper rubbing together, kind of like this. So Kaplan mentions a pleural friction rub is described as a gradient sound or vibrations heard during inspiration and expiration. Now, other signs, which are not really key, include unequal chest expansion, bronchial breath sounds, which are high-pitched sounds, and tactile fermentitis. This presents as more vibrations from a patient's back when repeating certain phrases and indicates denser or inflamed lung tissue. Now, a common NCLEX question here, a priority patient of who to see first. So a postoperative patient with suspected pneumonia with a normal temperature and a SpO2 of 94%, becoming, key term here, restless and agitated. So remember, the key terms there for hypoxia, restless and agitated, definitely mental status change. So anytime you see the word post-op or post-operative, you must think the worst case scenario for priority patients is acute respiratory failure, even if the temperature is not elevated and the oxygen saturation is not drastically low. So just look for the key terms, restless and agitated. Now, don't let the NCLEX trick you here on select all that apply questions. Pneumonia does not include tracheal deviation. That's typically from tension pneumothorax. And it doesn't include hyperresonance, which is typical for a regular pneumothorax, that air inside the pleural space. And it's not dull resonance, which is typical for a hemothorax, that blood inside the pleural space. But it can also happen in fluid-filled spaces too, like a pleural effusion, a complication of pneumonia, which we'll get into next. So the memory tricks, think T for tracheal movement as T for tension pneumothorax. And the L's for dull resonance, think blood or fluid for hemothorax or pleural effusion. And then the H for hyperresonance, just think high air. Okay, now for some key terms that you must know for your pathophysiology course. The main types of pneumonia. First up is lobar pneumonia. This is described as an infection of one or more lobes of the lung. Now, it's caused by Streptococcus pneumoniae bacteria, and a big complication is pleural emphyema. This is a collection of pus in the pleural cavity, where bacteria migrates and creates sort of a fluid-filled lung. It's one of the various kinds of pleural effusion, which we call pleural effluid, that fluid in the lung, which we'll cover in great detail in a moment. Now, in terms of manifestations and signs and symptoms, you should be sure to write this down. Number 1, lobar pneumonia has a sudden onset. And number 2, we hear ralls or rales, and described as crackles. This abnormal breath sound results from rumbling mucus within the lower airways, indicating that there's fluid inside the lungs. Described as a small clicking, bubbling, or even rattling sound. So we typically say rattling for ralls. And number 3, a big key term here, is rusty colored sputum caused by exudates. Now, it's just nasty lung butter that you would normally expect with any lung infection. It's basically pus-like sputum. Now, to get deeper into the patho here, it is due to the presence of RBCs, those red blood cells, and WBCs, those white blood cells, which get caught up in fighting infection. Now, moving on to bronchopneumonia. This is a diffuse infection in both lungs. The key term here is both lungs. And this is the key difference from that of lobar pneumonia. So the memory trick, think B for bronchopneumonia as B for both lungs affected. Now for the causes. There's several different microorganisms here that cause this bronchopneumonia. And the key manifestation or sign and symptom is yellow or green sputum with a productive cough. So clients with bronchopneumonia present with this green-yellow colored sputum due to the presence of multiple microorganisms affecting the lungs here. Now for the critical complications, these are priority for the NCLEX here. So pleural effusion, just think pleural E fluid. We see fluid that fills the pleural space, that space between the lung itself and the chest wall. Now this prevents full lung expansion, resulting in decreased gas exchange, so we get less oxygen in and less CO2 out. And this increased CO2 pushes the body into acidosis. So the key signs to write down are the 4 Ds. D for during inhalation, we see chest pain. D for dyspnea, that shortness of breath. D for diminished breath sounds upon auscultation. And then D for dull resonance on percussion. Remember, fluid-filled is dull. So don't let the NCLEX trick you here. It's not hyperresonance, as that's high air trapping. Now write down these 4 because these key signs came up a few times on Select All That Apply questions. Now the priority intervention for a pleural effusion is a thoracentesis to drain that fluid. The provider will stick a big, huge needle into the lung itself to drain that lung fluid. So a big complication is a popped lung or a pneumothorax, where air accumulates inside the lung space. Or even a hemothorax, where blood accumulates inside the lung cavity. So it's priority to report asymmetrical chest expansion and decreased breath sounds. 2 big key terms for thoracentesis. Lastly, the most deadly complication is ARDS, acute respiratory distress syndrome. We're talking deadly stiff lungs. So just think ARDS, we have hard lungs. And the key signs include, write this down, refractory hypoxemia. We're talking low PaO2, despite increased oxygen delivery. So the memory trick, just think the body is resistant to oxygen with refractory hypoxemia. And again, the first signs of low O2 is that altered mental status. And the top 3 again, number 1 is confusion, number 2, agitation, and a big one for number 3 is restlessness. Now we cover ARDS in its own full video, but again, these are the priority highly tested key terms. Now another complication is septic shock. This can occur if infection gets severe, as the body releases chemicals into the bloodstream to fight the infection. In result, the total body becomes inflamed, which can damage multiple organs within the body itself, causing them to fail. And this is known as MODS, multiple organ dysfunction syndrome. Naturally, we see cardiovascular collapse with low blood pressure and low perfusion, that low oxygen. So the memory trick, just think S for shock as S for severely low blood pressure and perfusion. So the key signs to know for septic shock is hypotension. The key numbers here is systolic blood pressure below 90 and MAP, that mean arterial pressure, below 65. Anytime these numbers get low, we know we gotta go. go seek help from the primary care provider and report these findings. So write that down, huge NCLEX tip. Now some other findings is a cap refill over 3 to 4 seconds, tachycardia, and early signs will see a fever over 100.4 as the body fights the infection. Now a late sign is hypothermia under 96.8. As shock worsens, we get more severely low blood pressure and worsened perfusion, so the core body temperature goes down. And we also see elevated WBCs and decreased urinary output. And the key to know for this is 30 mLs per hour or less typically means the kidneys are in distress. Now write these down. We cover it more in the full video for septic shock, but these are the most tested signs and always love to show up on Select All That Apply questions. Now in terms of risk factors and causes, the greatest risk factor for pneumonia, number 1, write it down, is advanced age. And the key number used on most exams is over 65 years old. Now, common exam questions love to give scenarios about an elderly population getting a respiratory tract infection or even the common flu that develops into pneumonia. This is called community-acquired pneumonia, since it was caught inside the community. Now, don't let the NCLEX trick you here. Environmental exposures are not the greatest risk factor than advanced age here for pneumonia. And neither is nutritional deficit or even obesity. So always think here, advanced age over the key number, 65 years old, is the number 1 risk factor for pneumonia. Now, another highly tested cause is for clients on ventilators who get VAP, ventilator-associated pneumonia. This happens when secretions in the mouth and throat contain bacteria that cause pneumonia. So it's critical to, number 1, reposition the client side to side every 2 hours. This helps to mobilize secretions. We do oral care and suctioning, again, every 2 hours, with chlorhexidine. These 3 key points are always on Select All That Apply questions for VAP. Now, the best indicators for VAP is, write it down, positive sputum culture and fever, and we also saw chest x-ray with new infiltrates. Now, don't let the NCLEX trick you here. Not lung sounds and not blood cultures. The best indicators here are diagnostics for VAP. Now, in general, prolonged immobility is another huge risk factor, since secretions are not mobilized and then get stuck in the body, as well as chronic diseases like COPD and clients who are immunosuppressed. But really a big one here is post-operative, or in other words, clients who have recently been out of surgery. We basically put the body to sleep with anesthesia, making the lungs low and slow. And now the alveoli are low and slow, or sleepy too. So we need to re-expand them to prevent collapse, that atelectasis, and prevent infection from settling in and getting trapped there. That's why we always turn, cough, and deep breathe, and always early ambulation after surgery, as well as use of the incentive spirometer to re-expand those closed alveoli. So a common exam question asks for the best indicator for VAP, that ventilator-associated pneumonia. And again, the best indicator is positive sputum culture. So once again, it's not elevated WBCs, and it's not even those blood cultures. So yes, those might be present too, but again, the best indicator for diagnosing VAP was the key term positive sputum culture. So write that down. Now, speaking of diagnostics, we can always do a chest x-ray that shows infiltrates. We're going to see elevated WBCs, that white blood cell count, over 10,000. And once again, a sputum culture will be positive. So a big test tip here. Cultures are always taken first before starting antibiotics. So just think of the double A's. A for antibiotics are given after cultures are taken. This is done to better identify the organism causing the problem so we can choose the best drug to kill it. And another common exam question here. The best blood lab value shows effective treatment of pneumonia after IV antibiotics. And the key term was white blood cell count. So for this particular question, it's not a sputum culture and it's not lung sounds. This question asks for a lab value for the key term after IV antibiotics. This will reflect a killing off of the infection inside the blood. So the best lab value reflects a decrease in WBCs, meaning a decrease in the army or defenses the body needs to fight the infection, since the antibiotics kill the enemy invaders. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love, share with a classmate, and even your instructor. See you guys in the next videos. Now for the case study on pneumonia. Mr. S is a 65-year-old grandfather who's admitted to the telemetry unit for treatment of pneumonia of the right middle lobe. His morning assessment reveals the following data: temperature of 38 Celsius, 100.4 Fahrenheit, heart rate of 110 beats per minute, that is regular, respiratory rate of 24, blood pressure 108/68, and an O2 saturation of 89% on room air. Okay, that's a lot of key terms here. But the biggest here is pneumonia. So always think P for pneumonia as P for a plague of infection. So naturally, with an infection, we would expect a high temperature and a high heart rate. Now, since the infection is in the lungs, the respiratory rate is increased, and the blood pressure is within normal range. But the O2 saturation is very low. Remember, normal is 95 to 100%. So question number 1, which additional assessments should the nurse perform first? Again, the key term here is first. First means priority. So think, what kills the patient first? In this case, the client has a plague of infection inside the lungs. So naturally, the respiratory and oxygen assessments would be the most critical. So the correct answer is breath sounds, looking for crackles, those ralls, and rhonchi from the fluid buildup and mucus collection in the lungs. Mental status changes is a big assessment, which is a big indicator of early hypoxia, that low oxygen, and respiratory effort and accessory muscle use, with a presence of a cough. Now moving on to the case study, crackles or ralls and rhonchi are noted upon auscultation. So question 2, what is the pathophysiology for auscultation of rhonchi in the client with lobar pneumonia? Remember, rhonchi is the rumble heard in the chest from mucus. So the answer, abnormal breath sounds are the result of the rumbling of mucus within the lower airways in clients with pneumonia. So remember, I call it the rhonchi rumble. Now question 3, which diagnostic studies does the nurse anticipate for this client? So remember, diagnostic studies are tests to confirm the diagnosis of a disease and also dig deeper into the severity of that disease. So as you can recall the key points from the full video, the correct answer is a chest x-ray, elevated WBCs from that infection, arterial blood gases, those ABGs, and sputum cultures, once again to test for the severity of the infection. Now question 4, how does sputum appearance differ for clients with lobar pneumonia versus clients with bronchopneumonia? Remember, lobar pneumonia only affects one or more lobes in one lung with that rust-colored mucus. And bronchopneumonia affects B for both lungs with that green-yellow mucus from multiple organisms. So the answer, clients with lobar pneumonia classically present with that rust-colored sputum due to the presence of, key terms here, RBCs, those red blood cells, and WBCs, those white blood cells. And clients with bronchopneumonia present with green-yellow colored sputum due to the presence of multiple organisms. The key term there is multiple organisms. Now moving on to question 5. The nurse notes that the client who was previously alert and oriented is now confused to place and time. Which further assessments should be completed immediately? Oh my. Okay, these are big key terms here for critical priority. Previously alert and oriented, and basically the client was awake and knows where they were at. But now the client is confused. This is a huge indicator for altered mental status. The key term is confusion, indicating early hypoxia, that low oxygenation, as you can see from the key points in the full video. So the question is asking for assessments to be completed immediately. So once again, think. The most accurate way for testing oxygenation and acid-base imbalances is, well, from an ABG, of course. So the answer, the client should have a STAT ABG drawn to assess for the development of potential respiratory acidosis. Yes, any new or sudden mental status change, the client should be assessed for respiratory acidosis, that high CO2, that high carbon dioxide. This can kill the client with that hypercapnic respiratory failure. So think high CO2 for hypercapnic. Now it's time for the practice questions on pneumonia. So question number 1. The nurse is assessing a client who presents to the clinic with the following signs and symptoms: fever, productive cough consisting of yellow-green sputum, and dyspnea on exertion. Bronchopneumonia is suspected. Which diagnostic test is most helpful to confirm this diagnosis? So pause the screen and try your best to answer the question in about 60 seconds or less. So let's break this question down following our question breakdown strategy. So number 1, first, look at the key terms in the question. And we have a lot of key terms here. So starting with the signs and symptoms: fever, productive cough with key term here, yellow-green sputum, super nasty. Definitely an infection here, and dyspnea on exertion. Pneumonia is suspected. So the question's asking for which diagnostic test is the most helpful in confirming the diagnosis. So number 2, always think of a few things you know about those key terms, specifically the diagnostic test of pneumonia. So think of the patho here. We have a lung infection. We need to visualize the lungs first and then look for signs of infection in the blood. So A, an arterial blood gas, those ABGs, this is incorrect because this measures acid base inside the blood for oxygenation, not necessarily for infection. Now B also is incorrect, the basic metabolic panel, that BMP. Now I call this the sampler platter because it tests for 8 different things, from electrolytes to glucose, but not for infection directly. Now C is a chest x-ray. Yes, we do this first to visualize the lungs and see if we have congestion from that infection inside the lungs. And D is incorrect, a complete blood count, the CBC. Now this is very close, but it's wrong, as a complete blood count does check for WBCs, which is likely to be high, indicating infection. But the best and most helpful confirmation is a chest x-ray first. Now question number 2, which client is at highest risk for the development of pneumonia? So pause the screen, you got 60 seconds. Try your best. Okay, let's break this down. Number 1, first, always look at the key terms in the question. Highest risk, and the second key term, development of pneumonia. And number 2, think of a few things you know about those key terms. So from the video that we just watched, we know that the number 1 risk factor is advanced age, over 65 years old. So look for the oldest client and begin there. So option A, an 82-year-old female client who is confused to place and time. Yes, as you can see, 82 years old is the most advanced age in our answer options here. And the client is confused to place and time, indicating hypoxia. Now B is incorrect, a 17-year-old with active upper respiratory infection. No, this client is young, and even though they do have a respiratory infection, the client's age does not make them the most at risk. Now option C, also incorrect, a 55-year-old male who drinks 2 to 3 beers weekly. So once again, this is not the oldest client in the answer options. And only 2 to 3 beers weekly? Come on, kid, those are rookie numbers. Bump that beer game up. I'm just kidding. But 2 to 3 beers per week is not bad. Now, option D, a 65-year-old female client who's scheduled for an elective hysterectomy. Very close, but 65 is younger than the 82 in option A. So option A would be the highest at risk. Now, moving on to question 3. The nurse caring for a client with worsening pneumonia expects which finding upon assessment? So pause the screen. You have 60 seconds. Try your best. Okay, let's break this question down. So always first look at the key terms. Worsening pneumonia and expects which finding upon assessment. And secondly, always think of a few things you know about those key terms. So pneumonia is that plague of infection inside the lungs, right? So we would expect the top 6 signs and symptoms. ALOC, that altered level of consciousness from low oxygen saturation. A fever from the infection, productive cough and yellow sputum, crackles inside the lungs from the fluid and infection, and dyspnea, and even pleuritic chest pain. Now looking at the options. Option A would be incorrect here. An O2 saturation of 81% and severe respiratory alkalosis. Oh man, okay, so this one is close, but it's incorrect. So yes, the O2 saturation is super low, but the key term here is respiratory alkalosis, which makes the whole answer option wrong. Now remember, respiratory alkalosis is from hyperventilation, but in this case, we would expect respiratory acidosis from impaired gas exchange as fluid blocks that gas exchange. Now B is incorrect because a non-productive cough and dyspnea at rest, no, we expect a productive cough with yellow sputum. So this would be wrong. And option C, decreased level of consciousness and hyperresonance on percussion. Oh, okay, once again, very close, but incorrect. So yes, the decreased LOC is expected from that low oxygenation, but we do not expect hyperresonance. Remember, this means high air, typical in a pneumothorax, which we don't have air trapping in pneumonia. Rather, we have fluid inside the lungs here. So we'd expect a dull resonance from the fluid buildup inside the lungs. Now D is the most correct option, coarse crackles on auscultation and a cough with yellow rust-colored sputum. Yes, all the key terms match up and are true here. So coarse crackles from the fluid-filled lungs from the infection and yellow or rust-colored sputum, again, indicating infection. All are key signs of pneumonia. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to Pulmonary embolism, also called PE for short, is a very deadly priority medical emergency. It's what happens when there's an obstruction of a pulmonary vessel, aka a blood vessel inside the lung, typically the pulmonary artery. This blockage prevents blood flow to the alveoli, where gas exchange is supposed to happen. So this blockage of gas exchange means a blockage of oxygen, which is seriously deadly since we get a decrease in the amount of oxygenated blood that gets out to the body, eventually leading to deadly hypoxemia, that deadly low oxygen. Now for the causes of a PE. Typically, it's caused from a blood clot, like a DVT, that loosens from another part of the body, typically the legs, and gets sucked into the heart and then pumped into the lungs, causing a blockage. But it can also be caused from other blockages too, like an air embolism or even a fat embolism. Therefore, the highest priority nursing diagnosis, and I would write this down, is impaired gas exchange, related to imbalance of ventilation and perfusion. Now again, write that down. This was the most commonly tested since it's the highest priority. Now as far as risk factors, for any type of blood clot in the body, from a DVT to even a PE, remember, estrogen birth control or oral contraceptives leads to an increase in blood clots. So the memory trick we use is the double E's. E for estrogen, just think E for emboli, those blood clots. This key term came up multiple times in many different question banks as the #1 risk factors for blood clots. Now, other risk factors that you should know is smoking, obesity, immobility, and even cardiac issues like atrial fibrillation or valve disorders, which can swirl the blood in the heart, leading to clots. But really, again, the most tested was that estrogen birth control. So just think the E in estrogen leads to an E emboli. Now, for the key signs and symptoms, don't just memorize here. All we have to do is think of the patho. So just think, we have a blockage that connects the lungs, right? So we'll get lower oxygen. Now, how does a patient with low oxygen present? Well, the number one sign is hypoxemia. And the three things you should write down and know is restlessness, agitation, and mental status change. These three came up multiple times on many different question banks as the number one sign of hypoxemia. But we'll also get chest pain, dyspnea and shortness of breath, tachypnea, tachycardia, and even anxiety. Okay, now for some key terms for your pathophysiology exams. So the manifestations or signs and symptoms typically worsen depending on the size of the clot here. So be sure to write this down. Transient chest pain comes and goes, progressing into a more serious sign of sudden dyspnea, chest pain, and hemoptysis. And hemoptysis is that coughing up of blood or blood-stained mucus, leading to anxiety and restlessness from that low oxygen. And finally, the late signs are severe crushing chest pain, hypotension, and loss of consciousness, as the blood clot cuts off even more oxygen to the brain and body. Now, as far as diagnostics, we can use a CT scan to take a picture of the lungs to find the clot. We can also use blood labs, and the key term here is high D dimer. Just think high risk for blood clots in the body. Now, Hesse mentions this. Indication for pulmonary embolism include positive D dimer. Now, focus on the positive here. Don't worry about those values. Exams and boards will give you the ranges. So the memory trick we use, just think D dimer, you have a dime-sized clot inside the body. Now, as far as treatments, we can use surgery like an embolectomy, which is a surgical removal of the clot. We can also use a vena cava filter, which sort of acts like a net to catch any new clots and preventing them from entering the lungs. And pharmacology, we got our anticoagulants and thrombolytics. The key difference here is that anticoagulants prevent new clots from forming. They do not dissolve the clot. That's key to know for your exam. So heparin, just think it acts in a hurry. It has a quick onset, but it's gone in a hurry. And warfarin, it takes a while to kick in, but lasts a longer while inside the body. So you'll typically see patients started on both inside the hospital. Now, as far as thrombolytics, just think B in thrombolytics as B for clot busters. So we have TPA and those ending in ACE, like alteplase and streptokinase. Again, very different from anticoagulants, where anticoagulants prevent the new clots and thrombolytics bust up or break up the existing clot. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love, share with a classmate and even your instructor. See you guys in the next videos. Now for the practice questions on pulmonary embolism. So question number 1. The nurse recognizes the primary risk factor for the development of blood clots that can lead to a pulmonary embolism as being which of the following? So pause the screen and try your best to answer this question in about 60 seconds or less. All right, let's break this question down following our question breakdown strategy. So first, always look at the key terms inside the question. So we have primary risk factors for developing blood clots, leading to a PE, a pulmonary embolism. And secondly, think of a few things you know about those key terms. So think risk factors for blood clots. Remember, the number one risk factor is estrogen-based oral contraceptives. Now, this is the most tested, but also anything that can limit the blood flow. Now, look at the options. C would be the most correct, as oral contraceptives think blood clots. Now, A, diabetes mellitus would be incorrect, because high blood sugar does limit blood flow, but this is not the primary risk factor for clots. And B, polycythemia. No, also incorrect. Now, polycythemia is a lot of RBCs, those red blood cells, that could lead to blood clots, but mainly like a brain clot, that CVA stroke. It's not a primary risk factor for a PE. Now, C, once again, is the most correct. This is the primary risk factor, those oral contraceptives for a PE. And D is incorrect, blood vessel trauma. Now, it's not the best primary risk factor here, but atherosclerosis, that atherosclerosis I call it, the scarring of the blood vessels could lead to limited blood flow and even blockages. Now, question number 2. The nurse is performing an assessment on a client being treated for a pulmonary embolus. Which assessment finding would be considered the most critical? So pause the screen and try your best to answer this question in about 60 seconds or less. Okay, using our question breakdown strategy, let's break it down. First, look at the key terms in the question. So the question states, a client with a pulmonary embolism, assessment finding that is the most critical. And secondly, always think of a few things you know about those key terms. So the number one sign is hypoxia. We see restlessness, agitation, and mental status changes, as well as chest pain, dyspnea, tachypnea, and even tachycardia. But again, the number one sign of hypoxemia is that restlessness, agitation, and mental status change. So option A, a heart rate of 61, no, we would expect tachycardia over 100, not 61. That's really close to bradycardia. Now option B, new agitation with an O2 saturation of 82%. Yes, the key term is new agitation. This is a big critical sign of hypoxia. And the option also includes 82% oxygen saturation, confirming that low oxygenation. Now, this is the most critical, as oxygen is the money of the body. So think no money, no honey. Or basically, no oxygen, no life. The body goes broke and dies. Now, options C and D are incorrect. Reports of a headache, 4 out of 10. Now, this is not the most important, as pain is a priority, but really only after ABCs and oxygenation. And D, a respiratory rate of 18. No, this is incorrect. This is actually in normal range. A normal respiratory rate is 12 to 20, so we'd expect dyspnea and shortness of breath with a clot inside the lungs. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz. Now for tuberculosis. It's a bacterial infection in the lungs caused by bacteria called M. tuberculosis. It's spread via the airborne route. So once inhaled, it spreads to the lymph and bloodstream. Naturally, this alerts the police of the body, the WBCs, our white blood cells, which I call the WBC Elite Squad, Septic Victims Unit. They respond by kicking out the infection to protect the body from invaders. So naturally, plasma B cells of the WBC squad come flying in to help identify the invaders. Like, we identified the foreign invaders. Engage. They shoot up the invaders with little name tags called antibodies, sort of like spraying them with identification trackers. These little antibodies help the killer cells, the macrophages and T lymphocytes, to properly identify the infection. So the macrophages typically gobble up the bad guys, kind of like a chubby cop. They love eating up every bad thing. They say, hey guys, I'm just here, to gobble up stuff. Yeah, give them to me. And the killer T cells, also called the T lymphocytes, or natural-born killers, my favorite name, but we call him the Mr. T cell, from the A Squad, who says, "I pity the fool who invades the body." Now, all these guys work together to try and kill TB, but can't. So they end up quarantining the TB infection into a little granuloma prison, which prevents the TB infection from spreading. Now, this shows up as a little circular dot on a chest x-ray, which helps with the diagnosis of TB. But a little side note here. If a client has decreased immune system or is on immunosuppressants with a suppressed immune system, they will have less WBCs to fight, so less macrophages and less T cells, resulting in our little granuloma dot not being there, which we'll cover in a moment. Now for the signs and symptoms, these are the key points for the NCLEX and your nursing exams. I would write these down. Number 1 is night sweats. Number 2 is anorexia, or that weight loss. And third, a big one here, is cough and hemoptysis, or basically that blood-tinged sputum. That's probably the biggest NCLEX tip right there. I would write that one down. And next, dyspnea and that shortness of breath, as well as fever and chills. So the memory trick to help you remember this, think TB. T for that terrible cough, specifically key term blood-tinged cough, and B for bad infection, including fever, night sweats, and a really big one here, weight loss. So I'd recommend pausing the screen and writing these down. These key terms love to show up on exams and boards. Now, as mentioned before, TB spreads via the airborne route, so it's priority to ensure that airborne precautions are to be put in place if the patient is suspected to have TB. So use these next memory tricks to help you on your exams. I know droplet and airborne precautions can get a little confusing. So use our memory tricks PIMP for droplet precautions and MTV for airborne precautions. So just think you're on air with MTV, like music television. And think of Pimp My Ride, like that old TV show, when you're dropping your lowrider really low. So for droplet precautions, P is for pertussis, I is for influenza, that normal flu every year, M is for meningitis, specifically bacterial, and P is for pneumonia, basically pneumonia. And for airborne precautions, M is for measles, T is for TB tuberculosis, and V is for varicella. Now, a lot of test questions come from PPE here, so write this down. For droplet precautions, number 1 is surgical mask and goggles, and number 2 is a single room. Now, ATI mentioned that we teach unlicensed personnel to wear a mask. And for airborne precautions, the number 1 thing is staff must wear N95 masks. The patient has to be in a negative pressure room, the door must be closed, and here is a tricky one, write this down. When you're transporting the patient must wear a surgical mask. Now, a few different textbooks had different things to say about this, but overall, surgical mask was the most recommended when a patient leaves the room. So guys, write that down. Not N95, but surgical mask. Now, a few question banks had a lot to say about TB and airborne precautions. So ATI mentions precautions for a patient suspected with tuberculosis. The answer is airborne precautions. And HESI mentions the first action for a patient with key terms night sweats, weight loss, hemoptysis, fever, and chills. And the answer is airborne precautions. And lastly, Kaplan also mentions a client with anorexia, low-grade fever, night sweats, and a productive cough. The priority action is to initiate airborne precautions. So you see how the key signs and symptoms are there. Exams expect you to know these signs and symptoms in order for proper intervention. Now, as far as diagnostics, we have 2 types. The intradermal skin test is the most commonly used in the United States, since the TB vaccine is not used, and a chest x-ray, which is used if the skin TB test returns positive, or if the client has had a TB vaccine, very common outside the United States. So for the intradermal skin test, this is done with an intradermal injection. Now, this test is also called a Mantoux test. It requires a 2 to 3 day window for reading. If the test is positive, then it'll show a red raised lump called an induration. And this induration will be greater than 15 millimeters. So the key term to write down is over 15 millimeter induration is positive for TST, our tuberculin skin test. Now, this means that the patient has been exposed to TB. And yes, they have the TB infection, but the key here is that they may or may not be in active form. Most students get this wrong. So the most accurate description of a positive tuberculin skin test is that yes, the patient has TB infection, but additional testing is needed to see if the TB is in active form. Typically, patients with active TB will show those active signs, like that terrible cough and active fever, as well as those night sweats and weight loss. And in latent TB infections, or those who have had the vaccine, will always show a positive infection, or basically positive TST, that red raised bump, since they've developed antibodies to that TB. Therefore, a chest x-ray is always done to rule out active TB, as well as sputum culture tests. So the key point to write down here is for a sputum culture diagnosis. Key terms is early morning sterile sputum specimen, 3 consecutive days. Not a blood test here. Many students get this wrong. So again, if the patient is suspected to have active TB and has a positive skin TB test, then 3 early morning sputum specimens are taken to confirm the diagnosis of active TB. Now, Hesse mentions this. The most accurate description of tuberculosis is most people who become infected with the TB organism do not progress to active disease. And Kaplan mentions the route of administration for a Mantoux test is intradermal. Now, a little side note, as mentioned before, clients who have a low immune system, like the elderly or even those on immunosuppressants or immunocompromised, they will lack the immune response, typically showing a very small induration. Now, lastly, ATI mentions a few key points. Sputum cultures are taken until 3 negative cultures. The key number there is 3. So just think 3 and you're free. And family members should be tested for TB. These 2 key points love to come up on exams as well as the NCLEX. So to help you here, let's cover the top 5 NCLEX tips as well as TB pharmacology. First is meds last 6 to 12 months. Guys, it's a long duration. Second is N95 mask is worn at all times. Third is that the family is tested for TB. Number 4 is sputum samples are done every 2 to 4 weeks. And number 5, 3 negative cultures on 3 different days means that you're no longer infectious. Guys, not 1 negative culture. The key number here is 3, and then you're free. All right, guys, that wraps it up for this segment. Don't forget to take your quiz and download the study guides. Now for tonsillitis and abscess. Tonsillitis is the inflammation of the tonsils, those little soft tissue masses located near the rear of the throat. When these guys get inflamed, it can lead to a life-threatening airway obstruction, especially in severe infections, resulting in peritonsillary abscess, where a collection of pus forms beyond the tonsils, resulting in very severe airway blockage. So the key sign to write down is a sore throat with difficulty opening the mouth and swallowing. Now, this is a priority patient and must be assessed first, since airway is always the #1 priority. Now, treatments include surgical interventions. Tonsillectomy is the simple removal of the tonsils. But since this region of the mouth and throat is very vascular, it's very sensitive after surgery and can easily bleed. So patient teaching is priority. So we must avoid bleeding after surgery. So write this down. We must avoid coughing or even blowing the nose, since this can cause pressure and bleeding. Secondly, we avoid sharp foods like chips and nuts. You got to keep that diet soft. So Jell-O, pudding, and applesauce are usually recommended. Now, no milk products are recommended as well, since this can coat the throat, leading to coughing to clear that throat, resulting in bleeding. And lastly, no hard toothbrushing or gargling, since this can irritate the surgical site. I'm telling you, bleeding is the big priority here and very important to monitor for. Now, the key signs that are priority post-op tonsillectomy. Number 1 is frequent swallowing. Number 2 is restlessness. And number 3 is persistent coughing. This typically means that the patient has a slow bleed that can progressively get worse. So watch out for those key terms on the NCLEX and your exams. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love, share with a classmate, and even your instructor. See you guys in the next videos.